Hey, this is Miss Roberts. I'm recording Chapter 23, Caring for the Child with a Genitourinary Condition. Okay, we're going to start on page 783. Just kind of explains the anatomy of the kidney, of course. Same picture in your book here. I'll just review that. On page 784, some weights and lollipops. You need to know the functions of the kidney. They include waste products, filtering the blood, maintaining fluid and electrolyte balance, which is sodium, potassium, calcium, and phosphorus, maintaining acid-base balance, and releasing hormones. One of the big hormones is renin, and that's what regulates our blood pressure. And that's part of the kidney function, is that renin, okay? There's more here. Of course, you know the GFR is important, right? That's our filtration rate, and that's done by the glomeruli. Alright, I want you to look on page 785. There's different types of dehydration. There's isotonic, hypotonic, and hypertonic, okay? Winks and lollipops here, you need to know this. Of course, dehydration is the loss of fluid in whatever way it happens. Isotonic is how we lose electrolytes and water deficits in the balanced proportion, so the equal amounts at the same time. We maintain a normal sodium limit of 130 to 150 milliequivalents per liter. This is the most common. Hypovolemic shock is the biggest one for isotonic dehydration. Okay, then we have hypotonic, and that's when the electrolyte deficit exceeds the water deficit. Okay, so that means the tissue starts swelling. Okay, we have too much electrolytes there. Okay, hypertonic is the most dangerous type, and that's when the water loss exceeds electrolyte. So you have hypotonic, you have more water than sodium. Hypertonic, you have more sodium than water. Okay, hyper is when the seizures happen. It's when the sodium is greater than 150. Okay, so there's a video here. We may or may not watch it, but pretty much just helps you to remember. So isotonic is like iso perfect. Okay, they're equal. Kind of help you remember. Iso perfect. Everything is equal. Okay, everything's perfect. Still dehydration, but this is in equal amounts. Hypotonic, you remember a hippo because the fluids swell. So a hippopotamus is big, right? So hypotonic. And then hypertonic, think of a skinny person, a runner that's hyper, right? They're running around, they're skinny, they're tiny. So hyper is when you lose the water and have more sodium. So just a good way to remember it. Then there's a good little definition here of the pathophysiology of dehydration. Just read through that. And of course, you need to know the normal sodium and potassium levels, okay? And I remember just, of course, the 130 to 150 for sodium. Potassium, 3.5 to 5.5. I remember that because bananas have potassium, right? And so you usually get a bunch of bananas that has usually 3 to 5 bananas in it. So that's how I remember that. These are, I'm going to give you a handout that has some of these on here. It's this handout right here, and it has a wink and a lollipop. So you need to know the types of fluid that are isotonic, hypotonic, and hypertonic. So these are our normal fluids, right? This is what we would hang just KVO or at a regular 125 rate. Hypotonic has less sodium, okay, and hypertonic has more sodium. So let's go back up here and look at the different types. So hypotonic is where we have more water than sodium. So what type of fluid would we give a hypotonic dehydration patient? We would give them hypertonic fluid to even that out and make them isotonic, okay? Not dehydrated, but isotonic, like even, okay? So we're adding more sodium to the hypotonic dehydrated patient because they have more water and less sodium, okay? For hypertonic dehydration, we're going to give them what? Hypotonic fluid, okay? Because they have more sodium than they do water. So they don't need that extra added sodium. We're cutting this in half, okay? Or less. We're not giving them as much sodium contained IV fluid because they already have too much sodium. Okay? So hypertonic dehydrated patients get hypertonic fluid. Hypertonic dehydrated patients get hypotonic fluid. All right, moving along. This is in your book on page 786. It's just the pathophysiology of dehydration. Of course, you start with the fluid loss. How did they lose it? Vomiting, diarrhea, fever, hyperventilation, burns. You can lose that. Hypovolemic shock, hemorrhage, diabetes, and then it goes on to get worse from there. So make sure you understand that. That's there in your book. All right, let's talk about the common disorders of urinary system. So, of course, UTIs, that's our main one, right? This is when usually E. coli gets into the kidneys, gets into the bladder, and we have a raging urinary tract infection, okay? Not good, not comfortable. We have some risk factors. So electrolytes are imbalanced, and it can become a pyelonephritis case. This is an infection in the renal pelvis, okay? It can cause renal scarring, it can damage those glomeruli, and there's lots of risk factors for that, okay? You need to know the risk factors. Winks and lollipops. Know the risk factors for UTIs. Big one is sexual activity. We call this the honeymoon disease, because back in the day where people were supposedly not having sex before marriage, and they would have sex on their honeymoon for the first time, they would usually get a UTI, and that's when they would not get up and empty their bladder after having sex. So all the bacteria from the sexual intercourse floated up to their urethra, into their bladder, into their kidney, hopefully not, but could, and they would get a UTI. So there's lots of things to do to prevent UTIs, okay? So I have a little clip over here, and it just tells you things that we can do, all right? Wiping front to back, of course, that's a huge one. Mothers need to start educating their daughters as soon as they're potty training them to wipe front to back, okay? Don't hold your urine. Empty regularly and completely. Sometimes you have to sit there for a few minutes to make sure your bladder is empty. Don't just hop up off the toilet, because that can cause a UTI. I know as nurses it's hard to take time to use the bathroom when you're working 12-hour shifts that turn into 14 and 16-hour shifts sometimes. But it's important to empty your bladder. Of course, like we just talked about, emptying your bladder after sexual intercourse, okay? Drink plenty of water. Shower instead of bathe. You don't need to sit in the tub, okay? I know lots of people bathe their kids in tubs, but it doesn't need to be a long, drawn-out process, especially little girls, because they have a shorter urethra, and that can cause UTIs. Climbs up that urethra, like we just said, and can cause a UTI. Keep the genital area clean. You know, the kids need to be bathed every day. Doesn't matter if they're not playing outside every day, but they still need to bath because they're having bowel movements, they're urinating. The genital area needs to be clean. All right. And we need to be teaching parents not to use wet wipes on little girls after they're potty trained. Now, as far as for their anus, their bowel movement, that's fine. But don't cross up, don't go to the front, do front to back with wet wipes, okay? Or even the flushable wipes. I use flushable wipes at home, but not for anything other than a bowel movement because they can cause UTIs. You don't need that, even if they're unsanded, you don't need that bacteria from the wipe in your urethra, okay? Reduce alcohol and caffeine, of course. You shouldn't see kids running around with monster drinks, energy drinks. This in itself is not good for them at all, not good for their heart. You hear kids dropping from heart attacks because of all these drinks. It's not good for your kidneys and your bladder either, okay? And then they have a D-mannose supplement. I take this every day. I have interstitial cystitis, which is pretty much a chronic UTI. It's just how my bladder was made. And this D-mannose is actually a supplement. It's an enzyme that cleanses your bladder lining, keeps your bladder lining of your bladder clean. This enzyme just kind of helps reduce those UTIs. Works very, very well. So if you know of someone, then of course, by all means, share that information and educate your patients on that as well. Diabetics. Bad thing to have high sugars, of course, you know that, but they cause UTIs. What do bacteria like? They like sweet spots to get infected in, right? Wounds like it, bladders like it, kidneys like it, so we need to keep those sugars under control in our diabetics. Going back over here to the risk factors, I want you to add 2 to this list. The first one would be a history of prior catheterizations. Okay, catheterizations. So a history of prior catheterizations. And then the second one is a family history of UTIs. So this can be genetics. All right, so those 2 you need to know. All right. Right above Nursing Insight on page 789, this is important to know that ammonia odor in urine is attributed to the breakdown of urea. Okay, so if your patient tells you that their urine is smelling like ammonia, that's the breakdown of urea. Okay, and that malodorous is usually indicative of a UTI. Okay. All right, on page 790, there's this risk factor box here. Another wink and lollipop, of course, we just talked about this, but teaching little girls to wipe front to back, to wear cotton underwear, not silky nylon underwear, because cotton is breathable, right? Make sure you understand these infection risk factors here, okay? And of course, these three that we talked about are important. Winks and lollipops, okay? All right. Let's go looking at page 791. These are some antibiotics that will help the UTI. Our big ones that we use are what? Bactrim and Macrobid and Cipro. That's the three top ones right there. You can use these other ones, but these are our big ones that we use, okay? Usually this is during pregnancy, Macrobid. And you can be on like a low-dose Macrobid for prophylaxis treatment. I've taken care of patients that have done that, and I took that for 2 years, 50 milligrams a day for 2 years, just for prophylaxis. Long-term use can cause lung nodules, so I stopped that because I don't need that. But those are big guns. So, you know, when you're looking at orders, make sure it's the right antibiotic. We've talked about this with babies getting GBS, right, from wrong antibiotics. So you need to know what you should know when you're reading orders from the doctor. All right, VUR, vesicoureteral reflux. This is where the urine flows backwards instead of down, it goes up, okay? The urine flows the wrong way. Normal flow is here. This is a normal flow, so it goes from the kidneys down the ureters to the bladder and the urethra. When it's vesicoureteral reflux, it goes back up into the ureters to the kidneys. So, we really need the waste product that comes to our bladder going back up into our filtration system? Absolutely not, okay? Make sure you understand what the VUR is, okay? And this first paragraph just kind of explains, that. And that in itself causes a UTI, right? The most common presentations for this to happen are recurrent UTIs, okay? You're going to keep a UTI, goes to your bladder, then all of a sudden it starts going back up. Severe abdominal pain, enuresis you can have, but acute pyelonephritis can develop as well from this. So make sure you understand the VUR. Go on down and talk about on page 793. It's at the top on the right in your book, under diagnosis, right before prevention. Right here, a wink and lollipop. So, diagnosing this VUR, you may have to do a renal ultrasound, but the big one is the anti-streptolysin titer, the ASO. Okay, so this is a big one to rule out that post-streptococcal glomerulonephritis. Okay, so the anti-streptolysin titer. Wink and lollipop, you need to know that that's one of the tests that you need to do to rule out vesicoureteral reflux. On page 794, it talks about hematuria. We know this is blood in your urine. You can see it on a dipstick. You can see it in a microscope. It can be more than 1+ is indicative of something's going wrong. Okay, looking for those RBCs. Glomerulonephritis. Okay, you know this is our filtration system, right? Glomerulus cleanses everything. We need those to function well. We need our GFR, our glomerular filtration rate to be in normal range. There's primary and secondary reasons this happens. Make sure you read through this paragraph and understand those. Here, not a wink and lollipop, but just read through them. But you do have some winks and lollipops over here. Under Nursing Insight, make sure you read through this. And know the signs and symptoms, okay? There's some winks and lollipops on this page. Post-streptococcal, so we know that's what? Previous strep. Previous strep throat can cause microscopic hematuria. I have that written in my book. I'll say it again. Previous strep throat can cause microscopic hematuria. Some signs and symptoms of post-streptococcal or just glomerulonephritis in general include hematuria. This is tea or red colored urine, okay? Edema that can be seen in the periorbital region, hypertension and headache, and then some ascites, which is that fluid shifting, right? So, you see a test question talking about some tea-colored urine, you're going to think about glomerulonephritis, okay? Some edema, periorbital region, that's just where it traps, okay? Around the eyes, think glomerulonephritis, because our filtration system is inflamed. Do you think it's doing the job that it should be doing as if it were normal? No. So the edema sets in around the eyes, okay? Diagnosing it, you're going to do some lab tests, some more winks and lollipops. BUN and creatinine are the big guns, right? So check your BUN and creatinine for your renal function. If they don't recover, the nephrotic syndrome can set in, and that requires a biopsy. Nursing care. You need to be closely monitoring these kids, okay? Monitor them for hypertension. And make sure, these are all winks and lollipops, that you're watching their sodium, their potassium levels, okay? Restrict those high sodium drinks, which are what? Pretty much all soft drinks, okay? And then you have a case study, so make sure you do this case study to put it all together. Alright, nephrotic syndrome on page 798. This is just talking about uremic syndrome. Skipping on through that. Nephrotic syndrome, okay? This is where it's a disorder, increased permeability of the glomerular filtration barrier, leading to excessive protein excreted from the urine. So nephrotic syndrome, you should have some crazy amounts of protein in your urine. You know something is going on. See the tiny clusters of blood vessels are damaged. And then you remember the RAS system, right? So make sure you understand, go back to your med-surg and review that RAS system. That's the renin, and what does renin do? It controls our blood pressure. It's our regulator. Angiotensin aldosterone system, okay? It activates that, resulting in edema, okay? So going back right here, all this is a Winkin lollipop, and this other. Characterized by 4 features, okay? Maybe I should highlight those in a different color. Know these 4. Very important for you to know. Proteinuria, hypoalbuminemia, hyperlipidemia, and edema. So nephrotic syndrome is characterized by these 4 clinical features. Winks and lollipops, okay? Signs and symptoms, of course, edema, and the periorbital and dependent, okay? Facial edema is another one. So I have facial edema written out here, okay? And I want you to add one. It's not an infectious disorder. You can't contract nephrotic syndrome from somebody, right? But I have that written. Not an infectious disorder. All right, and then I have some notes on a sticky note in my book that you need to write down. Nephrotic syndrome. I have ascites may be present related to fluid retention. A decrease in the abdominal girth means the treatment is working. So what does that tell you? You probably need to be measuring that abdominal girth daily, okay? So ascites may be present related to fluid retention, and we talked about ascites a while ago. But decreasing the abdominal girth means the treatment is working, okay? So remember I said proteins are huge, right? Huge proteins in your urine with nephrotic syndrome, 2+, all right? And some discharge, some more nursing care. Let's see. Nursing care right here. Some more winks and lollipops. You're going to watch that fluid and electrolyte balance, right? They should be getting daily weights, of course, and monitoring the degree of edema. Discharge instructions, education instructions. Low sodium diet. You need to be writing that in right there. Low sodium diet. Okay. All right. Let's move on to some structural defects of the urinary system. This is on page 799. Extrophy of the bladder. This is when it's a congenital defect and the walls of the bladder during fetal development don't fuse together. It's almost translucent where you can see inside the bladder. Sometimes it's turned inside out where the bladder is on the outside of the body because it does not, there's a congenital defect, okay? So, winks and lollipops here, this paragraph. Go back over here. Congenital defect in which the abdominal and anterior bladder walls do not fuse during fetal development. As a result, the anterior surface of the bladder is open on the abdominal wall. Extrophy comes from a Greek word meaning turning inside out. The tissue usually covers the bladder but does not form correctly and is separated so the bladder is fully exposed. Of course, they're going to be at risk for infection, right? So some more winks and lollipops here. You're going to teach them how to care for this. The nurse must teach the family of UTIs, symptoms of UTIs. If the infant's discharged prior to reconstructive surgery, they need to be taught to change the diapers frequently and cover the defect in plastic wrap to decrease the risk of infection or ulceration. Usually they try to get that surgery done immediately. let's go to page 802 and talk about renal failure, AKIs, acute kidney injury. So it's not referred to as renal failure in kids anymore. It's AKIs, acute kidney injury, not acute renal failure. What are some things that can cause this? Heart failure, anemia, low blood volume, nephrotoxic drugs, inflammation, and vasculitis. So just a good picture right there. There's an article here I can pull up in class to show you. But just make sure you understand what AKI is. Very important for you to know. They can suffer from multi-system failures, multi-system failures, organ failures. Another thing, winks and lollipops, is this respiratory compensation that happens, okay? Not a good thing. They start with Kussmaul's, or they end with Kussmaul's respirations, and that's the death breathing, right? It can be tachypnea, but the underlying disorder is low carbon dioxide pressure, okay, from that metabolic acidosis. Intracellularly, it does not breathe off or excrete as it should, okay? How do you diagnose this? Well, it requires, of course, a history, a physical exam. You need to be looking at all the lab levels, pre-renal, intra-renal, and post-renal. And I have a sticky note in my book with some things written down that you need to write down. The first one, AKI. You need to know the increased respiratory rate is common, and we just talked about that, right? Because of the carbon dioxide pressure, the low pressure, and that causes that tachypnea. Let's look at this. This talks about the pre-renal injury. How does that happen? And then the intrinsic injury, and then the post-renal injury. What happens? But these are just different types of AKI. I thought this was a good table. Kind of explains how it can happen pre-renally, intrinsically, and then post. So make sure you read through that. Now let's look at the 4 phases right here. This is not in your book, so I'll pull these up in class too. But you need to know the onset. What is oligouric and what is anuric? Anuric means there's no urine, okay? Oligouric means there's a little bit of urine, but still not putting out as it should, okay? Below 400 a day, as possibly as low as 100 a day. And we know we should at least be producing what? At least 30 an hour. So this in itself damages our kidneys. All right. You can find the different symptoms, knowing that something is wrong. So this explains the intrarenal or intrinsic, same thing as we talked about up here. So just make sure you do a history, Are they complaining of flank pain? Are they complaining of feeling faint? All of this can contribute to AKI. Maybe their blood pressure is low. And what controls our blood pressure? Renin, right? So if the blood pressure is low, maybe our renin is been compromised. Flank pain, that could be renal calculi. Okay, so something could be going on. Just make sure you understand that. Let's look at table 23.6 on page 803. So intrinsic is our intrarenal, right? It's important for you to know this. And then I want you to add one to the bottom of this for intrinsic renal injuries, some common causes. Winks and lollipops. I want you to add one that's aminoglycoside antibiotics. Okay? Aminoglycoside antibiotics. And what's an example of aminoglycoside antibiotic? Gentamicin is a big one. Okay? Gentamicin is an aminoglycoside antibiotic, and that can damage your kidneys. So make sure you know that. This is another picture of the pre, intra, and post renal. Just read through that. Good little picture. There's some more things in your book you can read through. On page 812, this talks about kidney transplants on 810. Hopefully we never have to do one of those on a kid. Vulvovaginitis, usually in our preteen girls. Amenorrhea, make sure you understand those, what that is, and secondary amenorrheas. Cryptorchidism, this is the absent or undescending of the testicles. This is on page 813. Usually have to have surgery. Common in a common anomaly in 2 to 4% of all newborns, males. There's a picture of it in your book too, here. We talked about hypospadias and epispadias before. Remember, the hypo is when the urethral opening is under the penis. Epispadias is when it's on the top. And that is it for chapter 23.